a 45-year-old female presents with progressive polyarthralgias, morning stiffness, and swelling. I am showing you radiographs of the wrist and feet. Please describe the findings.
The wrist radiograph demonstrates diffuse periarticular osteopenia, uniform joint space narrowing, and sharply defined marginal erosions without sclerotic borders. The feet demonstrate similar marginal erosions of the metatarsal heads, with uniform narrowing of the joints.
What is your primary diagnostic concern?
These findings are classic and highly characteristic of active bilateral rheumatoid arthritis.
What key radiographic features distinguish rheumatoid arthritis from osteoarthritis?
Rheumatoid arthritis shows symmetric uniform joint narrowing, periarticular osteopenia, and marginal erosions without sclerosis. In contrast, osteoarthritis features asymmetric narrowing, subchondral sclerosis, osteophytes, and no osteopenia.
Which joints in the hands and wrists are typically involved, and which are spared?
It typically involves the radiocarpal, intercarpal, metacarpophalangeal, and proximal interphalangeal joints. The distal interphalangeal joints are characteristically spared.
What is the pathogenesis of the marginal erosions, and where do they first appear?
Erosions are caused by inflammatory pannus secreting osteolytic enzymes. They first appear at the bare areas where bone is not protected by articular cartilage.
What are the classic late hand deformities associated with advanced disease?
Classic late deformities include the boutonniere and swan neck deformities of the fingers, along with ulnar deviation at the metacarpophalangeal joints.
What is a critical spinal complication of rheumatoid arthritis that we must screen for?
Atlantoaxial subluxation is a critical complication due to transverse ligament laxity. We must screen with flexion-extension radiographs, measuring the anterior prudental space prior to any general anesthesia.
Finally, what are your clinical management recommendations from a radiologist's perspective?
I recommend referring the patient to a rheumatologist for clinical workup and disease-modifying therapy. I would also suggest baseline cervical spine radiographs to evaluate for atlantoaxial instability before future surgeries.